Welcome to X-Ray 2022, the golden hour of trauma imaging. We'll begin with the old good news, bad news. The bad news is we won't be able to cover all the subject material in this presentation. The good news is what we will cover is going to be terrific. Although we have 4 categories of trauma hospitals in the United States, in emergency medicine, there is a national standard presumed to be equal throughout the U.S. In other words, when there is a nationally recognized protocol, the standard of care is the same, whether you're in a small rural hospital or a large university center. As we discussed, there are 4 different levels of trauma hospital in the United States, but all of them have to have the minimal standard. The initial trauma series of X-rays should include systematic examination and assessment of the alignment, bony structures, cartilage, and soft tissues involved in the injury. The standard series has become composed of X-rays of the chest, pelvis, and cervical spine. Based upon the expertise and equipment available in the emergency room, you may do more than the standard chest, pelvis, and cervical spine for us. We're going to look strategically through most of this presentation at the big 3, or the chest, pelvis, and cervical spine, done with mobile radiography or radiography that's integrated into the emergency room. But we will discuss also the other types of modalities that can be used in conjunction with this, such as CT and ultrasound. Often the physical examination is followed by conventional X-rays, as we discussed, a cervical spine, a chest, and a pelvis. If available, because of the lightweight, size, and ease of use, many emergency rooms are now performing what is called focused abdominal sonography in trauma, or FAST scans. Another modality that is used in emergency room evaluation of patients today is whole body CT scanning. It can be either specific sections or whole body CT scans. A fast scan with a trained physician takes about 5 minutes or less to perform. Basically, we're looking for 4 different areas sonographically: the subxiphoid, the left upper quadrant, the right upper quadrant, and the suprapubic view. Here we see images that demonstrate each one of those views. Another alternative in the emergency room, after using the initial presentation of the C-spine, chest, and X-ray, and FAST scan, is the addition of a CT scan, either a focused CT scan to do a specific section, or a whole body CT scan, which only takes seconds to cover the entire body. Everybody loves CT scans. Great information, complete information, and very detailed. The problem is, again, triaging the patient. If I have a patient that has a stroke, or I have a patient who has severe polytrauma, who goes first? So again, we look at triaging the patient turnaround time, and utilization of the scanner, plus the cost of CT scanning. Those are all negatives for CT in the emergency room. The positive is the fantastic images that it can create. We already know there is a national standard for the minimum quality of treatment in an emergency situation. So what would be the expected minimum competency for radiologic technologists working in the emergency room? Remember, the medical imaging professional is any individual who is legally authorized to perform medical imaging, and they must be educationally prepared and clinically competent. When we take a look at the minimum requirements, what we need to understand is that the radiographer has the expertise and knowledge of handling patients, caring for patients, basic imaging physics, anatomy, physiology, and the medical imaging processes to assess those needs. The radiographer has to be able to optimally record images and create or modify the details of exposure and positioning to get the information that the physicians need for diagnosis. While working in the emergency room, the RT should know how to avoid additional harm to the patient and obtain the images quickly and competently. They need to be able to recognize emergency situations and notify the staff if the patient's condition is changing. And finally, they need to remain calm and confident and do their job. Patients can suffer consequences when radiographers lack training and experience. The skill level and experience level of the radiographer who operates the image equipment and captures the diagnostic imaging exposures has a great and direct bearing on whether a potentially fatal condition is identified and treated or missed entirely. The primary role of the radiographer in the emergency room is to perform quality diagnostic imaging as ordered and as quickly as possible. During this process, they must practice ethical radiation protection and provide competent patient care. Radiographers do not interpret X-ray examinations for physicians and for staff or for family. They do not interpret examinations, period. That is the job of the physician or the radiologist. But the radiographer must be able to analyze the images to ensure that they have the diagnostic information required for treatment. In medical imaging, we do routine diagnostic X-ray exams. These are standardized exams. They have a criteria and a quality expectance, which we analyze after each image. Radiographers may find the acquisition of these exams redundant and mundane after doing them over and over again hundreds of times. Trauma imaging, though, is anything but redundant and mundane, and requires the radiographer to utilize all their skill and knowledge to acquire imaging exams and modify routine exams to demonstrate the information that optimizes treatment of the trauma injuries. When the radiographer is called to the emergency room, they should expect to be able to be exposed to both blood and/or body fluids. And they need to be able to utilize all of their protective personal equipment, PPE, for themselves and the patients and the healthcare team that is working with them. This includes gloves, drapes, etc. To be able to work in the emergency room, the radiographer must be able to be familiar and able to operate with the X-ray equipment that may be integrated into the room or the mobile X-ray equipment that they bring with them. To work with the emergency department environment, the radiographer needs to be familiar with ER protocols related to imaging in their facility. They also must be acquainted with the facility itself, so they can maneuver and position the equipment more easily during a stressful and chaotic situation. The radiographer must utilize protocols for standard precautions and transmission-based precautions so that they do not infect the patient, themselves, or their fellow healthcare workers. They also need to be in charge or aware of the personal protective equipment for radiation protection, such as thyroid shields, lead glasses, lead vests, etc. Let's talk about best practice for the radiographer. The best practice is, first of all, to anticipate what needs to be done prior to it being called for, and paying attention to detail so it's done correctly the first time. Also, you do not want to act outside your scope of practice. The scope of practice is what you are licensed for and trained for in X-ray school. And finally, you always want to be professional. By necessity, this presentation does contain graphic images of trauma. If you do not wish to look at these type of images, please stop here. When working in trauma, you'll find that radiography uses both standardized positions, and a lot of the times you have to modify those positions either through projection or exposure so that you are able to get the information without having to move the patient. Medical imaging plays a critical role in the rapid diagnosis and effective triage and management of complex polytrauma patients. The radiographer's role in trauma imaging is to be able to create images and working images of high quality in a minimal amount of time. Trauma imaging is a production of working images that are available during treatment to assess injury at that moment and document progress in treating the patient's injuries. These images are not routine diagnostic X-rays. The images are part of the care and treatment process and not just diagnostic documentation. Direct digital radiography should be used in the emergency department and images viewed on a non-diagnostic built-in screen. The images are subsequently uploaded to the PACS system where the images can go to a radiologist or physician utilizing a much higher quality monitor to be able to analyze the images and diagnose from them. We are just looking at working images in the emergency room. Working trauma images are created based upon the traditional, fundamental, routine diagnostic imaging, positioning, and exposure. The images are often modified to demonstrate the injury through exposure manipulation and positioning variations required to visualize the patient's specific trauma. To be able to modify and capture images and produce images of high quality, the radiographer needs to be able to communicate with the emergency room team to understand what they need visualized and have the knowledge and experience and the ability to create unique images to visualize specifically what they request. Working in the emergency room is often organized chaos, and patients do die. The radiographer must understand that in trauma deaths, we have a distribution of 3 periods of time in which it is most likely. The first or peak period is when the injury occurs, and those people never make it to the trauma department, or if they do, they will die sometimes during the second peak period, which we call the golden hour. The golden hour simply means the quicker they get in, the quicker they get treated, the better the possibility of them surviving. And the third peak is actually after they've been treated, which may be days or weeks later, which could be due to sepsis or even multiple organ failure. Time is the enemy in the emergency department, as noted by the golden hour. Producing a high-quality diagnostic image is the goal of the radiographer, but it must be done quickly and efficiently. Diagnostic imaging in the emergency department is paramount to an accurate, timely, and often life-saving diagnosis. Trauma radiography is a challenge, and the radiographer must be able to think quickly and creatively, because many of the radiographs that a trauma radiographer must perform have to be improvised. You must know theory involved for procedures performed and have the ability to critically think through the procedures to make the necessary positioning and exposure adjustments to get the image required. The #1 best preparation for good surgery, trauma, mobile imaging is knowledge and a good clinical experience in your education. Preparation for the trauma environment requires an understanding of the most common traumatic injuries and the role of the technology in working in the emergency department to produce images to demonstrate those injuries. You need to know common imaging procedures and how they are performed on trauma patients, including how to modify routine imaging. In trauma, we work around the patient. We don't want to move the patient. We want to keep them as still as possible. And there are several different body positions that we know of that we can work with. One of those being a decubitus position. And on a decubitus position, routinely you would roll the patient up on their side and wait for air to rise and fluids to fall. But if you can't rotate the patient up to their side for like a left lateral decubitus, what you can do is shoot a cross table decubitus. It's a different position, but fluids will fall and air will rise. The main thing you have to understand is technique, and that your exposure should not be taken till after about 10 minutes, which gives time for the fluid to fall and the air to rise. Again, the basics of X-ray are extremely important. Something as simple as the difference between PA and AP and upright and supine. Let's take a look at this portable supine chest exam. Notice the patient is on a backboard. Also, you'll notice it is going to be AP, so it is going to be probably about 40 inches SID, and with that we're going to get magnification in two ways. One, simply by the SID, and two, the heart will be magnified because it is farther away from the image receptor. Now with the patient supine, if they have any fluids, the fluids will be across the entire cavity. You cannot see any fluid levels. To be able to see fluid levels, you must get the patient either semi-erect or totally erect so that you can see air fluid levels. Obviously, positioning and technique are critical. Take a look at these two images. They are the exact same patient taken at the relative exact same time, the difference being the one marked A is a supine chest X-ray and the one marked B is a semi-erect portable chest X-ray. Notice the difference in the heart size and notice the difference in the exposure technique. To be able to modify routine exams, you must know basic exposure technique and be able to manipulate exposures, and also understand the alignment in positioning of the part, the X-ray source, and the image receptor. Rather dramatic, but it does make a point. One view in trauma imaging is no view. You need a minimum of two views, two orthogonal views like this, 90-degree angles, so that you can actually see where the different areas of trauma are located on that patient. Let's continue with the twos. We'll call it the rule of twos, okay? And the first one obviously is a fracture or dislocation may not be seen on a single image, and at least two views are required. Again, two 90-degree orthogonal views. Sometimes, if there's a joint space included, we will also need an oblique view. Another rule of twos is that in children, they have growth zones or epiphyseal zones. If those growth zones are fractured, you may need to get a comparison view of the non-injured side to see the damage done by the trauma. Let's continue with the theme of two. In the forearm or the leg, you need to have a minimum of 2 joints shown, the articulating joints at the proximal and the articulating joints at the distal end of these bones. Also continuing with the rules of 2, if we have a pediatric patient, sometimes when we have skeletal injuries, we're looking at the epiphyseal zones. The epiphyseal zones are the growth zones, and we may need to take a comparison view of a non-injured side of the patient to compare it to the trauma of the injured side. Also, when you're looking at fractures, if you have severe force fractures, you may need to get more than one level, or AP and lateral of the following. So here's how it works. If you jumped off a building or a ladder and you landed on your feet and you fractured your calcaneus, the amount of force that you did in jumping off that building would cause the imaging to require further examinations based upon that force. So if you jumped off and hit the ground hard enough to fracture the calcaneus, it would be important to get an x-ray of the pelvis for shear fractures and an AP in the lateral of the spine all the way up for compression fractures. Some fractures are notoriously difficult to detect soon after injury, and so here's another rule of 2. We may have to get a second image later on, and we can only demonstrate the fracture as it begins to heal. Let's take a look at the rules of 2. Here's a very simple explanation. We have the forearm of a child. On the first image, we only see the distal area, the wrist of the forearm. We do not see the proximal area, the articulation of the humerus with the forearm, the elbow area. On the bottom, we notice that we have the wrist cut off, but we do see now the elbow. In both images, you'll see the angulation of the bone. The bone is angled up because there is a dislocated radial humeral joint. Now we notice the difference in 2 orthogonal views or 2 90-degree views. On one view, it is difficult to see the fracture. On the other, the spiral fracture shows definitely well. We discussed the fact that pediatrics have growth zones or epiphyseal zones at their joint spaces. If you've injured one joint space, it is common to take a comparison view of the non-injured joint space to make a decision about the degree of injury. This only occurs after the first joint space has been demonstrated. If it's already an obvious fracture and the other side, or side we would compare with, has no trauma to it, we don't need to take that second view. As we discussed, the most common initial views for a trauma patient nationally are a cervical spine, chest, and pelvis x-ray. In the remainder of this presentation, we're going to look at analyzing the cervical spine views, the chest views, and the pelvis views, not for interpretation, but to recognize the trauma and what needs to be done. Before you take any x-ray examination, you need to make sure that you're not superimposing anything over the patient, whether it's lines that are in the emergency room bed, tubing, or the patient's own jewelry. Also, before you go into an emergency situation, you should review the different types of views that we can get to show or demonstrate the same area of interest, such as the sunrise view here. Notice there are 4 different positions that you can demonstrate the patella. Understanding how you're able to view these and knowing the basis of two-part film alignment, you should be able to do most of the parts in the body just by visualizing them and being familiar with alternative views. Let's take a look at a couple things we need to take in consideration when we're modifying views in the emergency room. One of the things that we would look at is exposure. So I have 40, 56, and 72 inches here, and the relationship between mass and KVP. The distance would be 40 inches if the patient was lying, say, supine on a gurney in a trauma room. If we were able to get the patient semi-erect, it's usually about 56 inches from the end of the gurney to the image receptor behind the patient's chest. Whereas in a routine diagnostic room, we generally shoot a erect PA chest at 72 inches. Well, what does the SID help us with in the relationship with mass and KVP? Well, very simply, by the inverse square law, we know that if we go from 40 to 56 and 56 to 72, at each juncture we would have to double the exposure. Whether we double the exposure by doubling the mass or going up 15% in the KVP, we still have that variance. Conversely, when we go from 72 inches down to 56 and down to 40, we have to be able to decrease the exposure. A lot goes into creating images, not only looking at the exposure, but what about the patient's relative position when they go from 40 to 56 to 72? Is there some geometric magnification and air fluid levels we need to understand when we change the patient's position? Yes, there are. So if we take a look at the source to object distance and the object to image distance, we will notice there are magnification factors that need to be taken into consideration. Also, we would generally like to have the area of interest, or the part, be parallel to the image receptor and the image source being at a 90-degree angle. If that is not the case, we are going to get geometric distortion. Being able to understand geometric distortion, positioning, and technique adjustments, you will be able to modify most of the diagnostic routine exams without moving the patient to demonstrate the anatomy required. Here we're going to take a look at a routine position, the navicular view or the scaphoid view, which we utilize to elongate or to distort the bone so that we can see the bone fragments better. We often see this in conjunction with a Colles fracture, but what we do here is we do not use a 90-degree angle. We distort the angle to be able to do what? To elongate the bone. Using this principle, we can do many things in a trauma situation with little imagination. Exposure has to do with subject contrast, and subject contrast is relative to what tissue density we're going through and the thickness of those tissues. We usually have bone, fat, air, and muscle, and sometimes if there's a bullet or something else in there, we have metal to look at. Understanding the relationships of KVP and mass and SID and manual technique, you should be able to automatically get a ballpark idea of every single exposure you need to make after taking a first exposure on that patient. What am I talking about? Okay, let's say we get a tib fib. If I take an AP tib fib and the exposure comes out really good, will I know how to do the rest of the extremities like the knee and the foot? Yeah, I'll know the exposure for those, but if I know the exposure for the knee, I pretty much know the exposure for what? The shoulder. And if I know the shoulder exposure, I pretty much know the humerus exposure. And if I did the tib-fib, I would probably correlate that exposure to what? The forearm. As you can see, we're talking about baseball park exposures or relative exposures. It's a place to start with very quickly where you can compare areas and tissues and create an exposure or modify an exposure to your advantage. Remember, the tissues may not be the same on a normal person as they are on a person who has suffered trauma. There may be air forced into the tissue, or there may be fluids there, or bone fragments, or bullets, etc. In treating trauma, the time it takes to create an image is crucial, because time is crucial in all of the interactions that the trauma department has with the patients. The faster they can diagnose and treat the patient, the better quality response the patient will have in the long run to the treatment. If we take a half hour or an hour to get a cross-table lateral C-spine and the patient has a fractured pelvis, they'll bleed out before we ever get back to get that fractured pelvis. This is what we're talking about, time being a crucial element. Trauma radiographs must be taken with a minimal amount of patient movement. And this is why we're talking about modifying or adapting different techniques and different positions. Unless you work in a trauma center, you'll probably be limited to a mobile X-ray unit. The mobile X-ray unit has more difficulty in positioning than if you have a unit devised for a trauma room, where the idea is that you can move the image receptor and the image source around the body part. The primary challenge of the trauma radiographer is to obtain a high quality diagnostic image on the first attempt. As we said, the national standard is for the big three: cervical spine, which would include a lateral, an AP, and an odontoid view, a supine chest film, and an AP pelvis. Sometimes we think about the big four, which would be a cross-table lateral of the spine if there's an injury in that area for the thoracic or lumbar. Here we see a pretty dramatic image, but notice that if there is any hint of trauma to the spinal column from the thoracic and lumbar area, we should be able to take one view, a cross-table lateral, and be able to see if we're able to move that patient or has the spinal cord been transected. About 40% of all medical images are the thoracic or chest area. It is one of the areas that we take most frequently because there is a lot of information that we can garner from a chest film. We know what a good normal chest X-ray would look like, with both lungs expanded and a light visualization of the T-spine through the heart and no rotation. But let's take a look at what an abnormal chest X-ray would look like. If we take a look at the X-ray to the right, we can see an air bronchogram in the upper right portion of the lung. This is usually indicative of a disease process such as pneumonia. The visibility of air in the bronchi because of the surrounding airspace disease is called an air bronchogram. This differs from having air fluid levels or fluids in the lungs. Here we're going to see what an air fluid level looks like. Now we see an air fluid level on our drawing as opposed to the air bronchogram. The patient needs to be upright to be able to measure the volume of the air fluid levels. If the patient is supine or semi-erect, the fluid spreads throughout the cavity and we do not get an accurate measurement. Another common abnormality that we'll note on the chest x-ray is heart disease. If the heart is enlarged and the aorta is big, then the left ventricle is going to be enlarged. We take a look at the Cardiothoracic Ratio. If the ratio is greater than 50%, we know we have some sort of problem. If it's less than 50%, it is normal. Of course, this again changes by position, because as we stand up and become erect, our heart becomes smaller as gravity pulls the lungs and the heart down. If we're lying down supine, then what will happen is it will enlarge the heart, and we sometimes mistake these enlarged or magnified hearts for a problem that does not really exist. By simply changing the patient's position, we can rule out a vascular cardiac problem. So we've looked at heart disease because a lot of patients come in, they have regular disease such as pneumonia or heart problems in combination with the trauma. Here we see a chest x-ray, nice inspiration, not any rotation, heart looks great, but there's a problem. If we take a look at the problem, what we're going to see is that the gas bubble in the stomach is displaced towards the midline. That's indicative of a spleen being pushed over or a splenic rupture. This comes from trauma. So now that we can see the difference between things that occur naturally and things that occur traumatically, we're going to focus on what happens with trauma. If we take a look at this portion of the chest, do you see any problems? Can you see the subcutaneous air that is in the patient's tissue? Do we see the broken ribs? So again, we're looking at a patient with trauma here, and we have a lot of different areas to ascertain. Remember, we're not only looking at bone, but we're looking at soft tissue, cartilage, and alignment as well. Obviously, this chest would have been a lot better if the apices were included, but since it is a supine trauma chest, we can see something on the image. First of all, most of the chest looks normal, except for all that sub-Q air, which means that we have had a lot of pressure going in that area. So now that we see all the sub-Q air, start looking down the ribs and see how many fractured ribs you might find. What are some of the signs that a patient needs immediate attention when you're looking at the chest x-ray? We want to see if there is a life-threatening problem. This can be anything from a tension pneumothorax to a massive hemothorax or flail chest. Also, what we can see is if there is a widening in the mediastinum up around the aortic arch, etc., we're looking at the real possibility of a major vascular problem, a dissecting aorta. We can see the seatbelt on the patient's torso, and down below we can take a look at the aorta. With contrast, it looks like a candy cane. And notice how it looks like it's broken at the neck of the candy cane? That's a dissecting aorta, life-threatening. Let's take a look at this chest x-ray and see what we see. Is there any major vessel injury or anything else going on? Yeah, what I can see here is, to begin with, we have a chest tube in. That chest tube means that we probably had a pneumothorax. So we've had some injury to the area. How about any other types of clues here? Costophrenic angles look pretty good. Cardiac ratio looks pretty good. It doesn't look rotated too badly. Can't see the T-spine through the heart as well, but it doesn't look bad. Oh, wait a minute here. All of a sudden we notice that the mediastinum is widened. What was that widened mediastinum for? Vessel injury. Not only do you have a widened mediastinum, but you may have an indistinct aorta, not be able to visualize it as well. And you'll also see a difference in the right mainstem bronchus coming up higher, being displaced. Or you may see a pleural cap, or the NG tube itself, the nasogastric tube that they've put into the patient. Notice how this is deviated over. It's pushed over to the right. Well, what would be pushing it over to the right? There has to be something on there pushing it to the side. So what we see here is that deviation means that we have a number of things in this image which suggest not only a pneumothorax, but possibly a aortic aneurysm. Our job is not to interpret images, but to analyze images. And to analyze images, we need to know what we're looking at. Now, on this image here, we're looking at a portable chest x-ray, and we see some clues there. They have to do with the vascular damage. Now remember, about 7% of the people that do have major vessel problems are not going to have an abnormal chest. Their chest will look normal. The biggest clue that we use is the mediastinum, and we can see the mediastinum has become enlarged. Or we look for an indistinct aortic knob, left pleural effusion, or the trachea being pushed over and the bronchus being, right mainstem bronchus being pushed over to the right. So something has to be shifting these things over. Again, we're not trying to interpret the chest x-ray. We're trying to see what areas need to be visualized, especially with a one-shot major trauma image. Here we can see a major trauma supine image of the chest. Yes, we have areas cut off, but we do have some knowledge here from what is on the chest x-ray itself. If you analyze this very closely, what you're going to see is, first of all, broken ribs. Next, we'll see a widened mediastinum and an obscure aortic arch. You can see the obliteration of the aortic knob right there. Now we see the tracheal deviation. The trachea is pushed over to the right. Remember, we go down and we divide up between the right and left mainstem bronchus there. And if we had our chest tube in, what we're going to see here is the patient has cracked ribs and we had to reinflate that chest some. The NG tube, nasogastric tube, is also shifted to the right. Again, we are looking at major vascular or vessel damage. There are many traumas to the chest, and often you get multiple traumas to the chest. Here we see a flailed chest. If you take a look at the flailed chest, what we're looking at is the inspiration and expiration. There's going to be a difference in the lung. Now, the flailed chest x-ray you see over here to the left is one in which the x-ray shows the lung has already been reinflated. So let's go on to our next one and see what it looked like prior to having it inflated. Well, the first chest x-ray we're looking at on the left here is a normal chest x-ray with normal anatomy. On the right, we're looking at the flailed chest x-ray, and notice there is no air volume in the entire right side, and all of the ribs have been crushed. We have to put a tube in there to inflate that area back up and stabilize it. Here's another look at that same chest x-ray after it has been reinflated. We need to make sure that we get the entire area of interest on. Sometimes you have to take multiple films to be able to cover the entire area. We're going to take a look now at the lower portion of the chest and diaphragmatic injuries. This is an upright chest x-ray, and you'll notice that the diaphragm is indistinct. But we have a good quality chest x-ray. There's not a lot of rotation. When you're looking at the SC joints, you can see the T-spine through the heart, and we do have some magnification. Let's see what happens if we have a little bit more damage in this area. But this is showing the beginning, the indistinct diaphragm. Now we have some major trauma, and if we take a look at this chest x-ray, you'll notice that they have a chest tube in on the right already, and that we have an elevated and irregularly high diaphragm. It's elevated so high that it has to be ruptured because we can see the colon and the gas bubble from the stomach up underneath that elevated diaphragm. You'll recall that we talked a great deal about technique as far as exposure goes, the correct exposure, and positioning. If we take a look at this x-ray, notice the patient is sitting upright. It's a mobile upright. What we do see again is it's very difficult to see the lungs. They're almost whited out. And all of a sudden we take a look over and we can see the flexure of the colon way up into the chest. This is a hemo being blood, pneumo being air, diaphragm and stomach rupture. Again, what we're looking at here is not to interpret the radiograph, but to understand what is a good quality image as far as penetration and positioning. If you think this was just underexposed and you darkened it out, what would happen? When we take a look at this chest x-ray, obviously the patient still had the bra on. There is air around the mediastinum. We have air in the mediastinum, and we can see that we have an endotrach tube in. When we see the endotrach tube, what we're looking for is it going down the trachea, and it should be about an inch above the bifurcation of the trachea, which is the carina. Interestingly enough, if you take and you're putting a trach in and it goes down too far, it'll usually go down the right mainstem bronchus. The reason it goes down the right mainstem bronchus, it is more vertical and larger in diameter. When it does go down the right mainstem bronchus, you will collapse the left lung, as we see here. This image shows a very easy to see, simple pneumothorax, collapsed lung. A lot of times they are not so simple to see, and a great deal of that has to do with taking inspiration and expiration images and also your exposure. Here we see another huge pneumothorax. Notice on the right lung there are no lung markings on the right except for a small portion. So what we're looking at here realistically is anytime you have a pneumothorax, you're going to collapse the lung down. So the viable lung tissue will still have lung markings, but the area that is collapsed will not. The others were pretty easy to see. Show me where this one is. I'll give you a second. Ah, there we go. So as you can see, technique is very, very important. Also making sure you get both an inspiration and an expiration film for a pneumothorax. Here's another collapsed lung, but it's difficult to see because we have different types of things such as a pacemaker in the image. But let's see if we could make that out. We're going to look for viable lung tissue and collapsed lung. So we're looking for lung markings, versus no lung markings? Ah, there we are. We can now see the area that has collapsed. We see the lung markings inside and the area that's collapsed to the outside. Now let's take a look at the chest x-ray here on our inspiration. Do you see the pneumothorax if there is one there? Let's do an expiration chest. Notice the difference. We have a tiny area here that has lung markings left, and the majority of the lung is collapsed on expiration, while on inspiration it is almost difficult to see the lung markings versus the collapsed area. Changes of lung pressure, either increased or decreased volumes of air within the thorax, will automatically press on or move some of the anatomy from its original position. If the pressure pushes it to the left, we're going to move the heart over to the left. Conversely, if we don't have pressure there and we have pressure coming in from the right, we're going to go ahead and move it over to the right. So changes in volume are important. Here we see one of the most dangerous chest x-rays that you will encounter when you're in trauma situation. It's called a tension pneumothorax, and the pressure is completely pushing the heart over, and it can cause death. Here we can look at two emergency type chest x-rays, both of them pneumothoraxes. One is displacing the heart to the right, and one is displacing the heart to the left. The first picture, we're moving the heart over to the left, and you can notice that entire area is collapsed, and if you follow the trachea down, you'll see the bifurcation of the trachea, the area of the carina there, and how far everything is pushed over to the left. Conversely, if we take a look at our image on the right, you'll see a lot of sub-Q air, a lot of fractured ribs, and look at that heart pushed all the way over to the right. We have to get in there and stabilize the pressure on either one of these, because in either case the patient could die. So again, a tension pneumothorax is a real emergency. Progressive loss of air into a pleural space, causing a shift of the heart and the mediastinum structures away from the side of the pneumothorax, will compromise the ability of the patient to breathe. If we're going to see fluid in the chest, we'll usually see it in the Costophrenic Angles. In the Costophrenic Angles, we want to make sure that the patient is in an upright position so that the fluids fall and the air rises. We can have them in an upright position or a decubitus position. In either case, what we're looking for is fluid falling and air rising. Here we can see in both cases the fluid has fallen and the air has risen, but it takes time for the air to rise and the fluid to fall. That's why it's logical when you're planning what you're doing sometimes. When a patient comes in and you're looking for an upright abdomen, etc., go ahead and get the images upright to begin with of the abdomen before you lie them down and do a KUB type abdomen, an AP abdomen, and then set them upright, because now you've wasted 10 minutes. When you did the chest x-ray upright, they already had the air fluid levels where you wanted them. Just logic. You'll note in all these chest x-rays, positioning and technique are extremely important. And you'll notice due to the patient's trauma, it's very difficult to get them positioned correctly. So what we want to do is take a look at the bony abnormalities to begin with. So we'll kind of take a look and go down the ribs and all. And let's just go down this chest and see what we have. Well, we've got rib fractures. Mediastinum looks okay. Appears there's some pulmonary contusion over there on the right, some sub-Q air on the right. And let's take a look at our NG tube, and it's going down right down the middle, so we're okay. But also notice we have what? We have a collapsed lung on the left, and they've got a chest tube put in there. So here we see broken ribs on the other side, as well as the pulmonary contusion up here, and down here we see the sub-Q air in the tissues, and you can see that there's a kink in the chest tube right here. And also we can follow that NG tube down. It looks okay, so we're not going to worry about the vasculature in the sense that we don't have a really wide mediastinum, and the NG tube looks fine. These are things you need to analyze while you're taking a look at your images. Make sure that the areas that you want to see are shown and that they visualize what needs to be demonstrated. Here to interpret the chest x-rays, but we darn sure need to see what is on the chest x-rays to make sure we've demonstrated all the trauma correctly. Now, if we take a look here, what do you see? How about this pulmonary contusion? Oh, wait a minute, there's also a scapular fracture there. So again, it makes a difference in how we take our images, both positioning and exposure. What happens when we have a collapsed lung, or we have a collapsed lung and there's blood in the lung? We have what's called a hemothorax, blood in the lung. Now this patient here on the left image is a supine chest x-ray, and you'll notice the density is unique or unilateral or homogeneous, however you want to say that. On the other side it's pretty all the same. And the reason is because they're lying down and all the blood spread throughout the entire area. If we want to be able to see it correctly, we're going to have to get the patient into an upright position or take a cross-table lateral decubitus to see the volumes of blood and air. So here we see a pneumothorax, a hemothorax, and a combination Hemo Pneumothorax. You have different tissues here and different densities. Is it going to make a difference on your exposure? You bet it is. With the pneumothorax, what we're looking for is lung markings. And so with lung markings, we have to be very precise on our exposure to be able to discern the difference between areas that have no lung markings, the collapsed lung area, and areas that do have lung markings, the areas that are aerated. Here we see an upright image of a hemothorax. Notice on the patient's left side, we almost have a straight line going across, and you can see the differences in the density between air and fluids. Remember, we had a tension pneumothorax, which could have the patient dying. It was a dire circumstance. We can have a hemothorax, a tension hemothorax, but instead of having air displacing the organs, what we have is blood filling up the lung and displacing the organs. In both cases, the patients need to be taken care of immediately or they might die. And lastly, what we're looking at here is a combination, a hemopneumothorax, air and blood in the lung. And so again, positioning and exposure are critical. You can see in the upright here the differences in the pneumothorax and the air fluid levels for the blood down in the lung, because as they sit upright, the blood falls and the air rises. Notice there's no lung markings on the one side over here and lung markings inside. So we have a combination hemopneumothorax. So if possible, you'd like to get a PA and a lateral or an AP and a lateral, And if you cannot get a PA and a lateral or a cross-table lateral, do a decubitus, because we're looking for the movement of air and fluids. Well, that was the highlights of one of the big three, the chest x-ray. Next, we're going to look at the cervical spine. And interestingly enough, the most common reason for a missed spine injury is a technically poor or inadequate radiographic series. Here are the four most common reasons that cervical spine fractures are missed by ER physicians. The first one is failure to obtain the images indicated. I can't get C7T1, I can't see the odontoid, etc., etc. The next one is inadequate images. The images are of poor quality. Next would be misinterpretation of the images. If we have quality images, the doctor can still misinterpret them. And lastly is the images fail to adequately visualize the injuries correctly. So we're going to take a close look at cervical spine imaging in the emergency room. Most patients come in from a EMS or ambulance service wearing a C-collar. This is to stabilize the neck because there is a worry about spinal cord injuries. There are a number of mechanisms for injury ranging from blunt or penetrating trauma to compression, which is an upward or downward force, hyperflexion, and hyperextension. Extreme rotation of the head or trunk can also cause spinal column injuries, and there are also injuries that do not damage the spine or the ligaments, but transmit the force through the cord, resulting in spinal shock, where the spinal cord actually swells, and this, of course, impacts on the ability to feel paralysis. The good news is that the incidence of vertebral column fracture is very low. It is less than 3 to 6% of all skeletal injuries. We utilize a C-collar on almost every patient that comes in to prevent any type of trauma to the neck and the spinal cord. But after clearing the spinal cord or the neck with a lateral C-spine, we are able to discard the C-collar in most cases and continue with the examinations, which should include another lateral C-spine so that we can see the curvature of the spine. Injuries of the cervical spine are among the most serious injuries that can result from falls, industrial accidents, automobile accidents, and athletic activities. If you take a look at transcending the spinal cord, you will see that if you actually transect the spinal cord between T1 and L1, you can end up with paralysis, partial paralysis. But if you transect the spinal cord from C4 through C7, you can end up with complete quadriplegia. And if you transect above, you may end up with death. We see that the central nervous system has lots of bony protection. As we look at the spinal cord, you'll notice that it is surrounded by the vertebral column. In the vertebral column, we actually have areas that allow nerve roots to come off of the spinal cord and go to the body. These areas are called foramina. As we discussed, when you're looking at the cervical spine, the area in which the cervical spine cord is disrupted or transected makes a difference because it has pairs of nerves that come off of that area. That's why if you get a C1, C2 fracture sometimes with a dislocation, it's called a hangman's fracture. And of course, with a hangman's fracture, usually you die. But on the other hand, if we're taking a look at the nerves that are coming from the spinal cord to the body, we'll note that the phrenic nerves, which control the lungs or the breathing of the lungs, the respiratory system, come off of C4. So this is why it's important to look at C4 through C7. And if we end up transecting the spinal cord at C4 through C7, we can end up with possible death or paralysis. This animation demonstrates the articulation of C1 and C2, the axis and the atlas, and how they are supportive of each other and allow for movement within the cervical spine. To the right, we can see that we have a hangman fracture. Dislocations of the cervical spine. Dislocations and dislocated fractures usually do mean the spinal cord has been transected. Severe injuries to C1 and C2 typically result in death. The odontoid process is involved in about 10% of all spinal fractures and is sometimes seen with the dens displaced. The emergency room has a number of protocols that they have for routine traumas. Here we see a cervical spine clearance protocol, which tells us exactly what we should do. And notice the first thing we do is clinically clear the spine. Then we have to see, does it clear or does it not? If not, where do we go from there? Take a lateral C-spine, and if there's still a problem, do we do an MRI or a CT scan? So again, this shows us how we go through the clearance of the C-spine if we're the physician in the emergency room. When the physician in the emergency room gets a good lateral C-spine x-ray, they evaluate it for not only the vertebra or the bony aspects, but for the ligaments, joint spaces, and how the biomechanics of force may have damaged that area. When we talk about biomechanics, we end up with axial, which is a force coming from the top, which can cause compression type fractures. Extension, whereas we lean backwards and end up having a force going to the back, commonly known as whiplash or other types of injuries associated with this, and rotation type of injuries. To ascertain these type of injuries, we need to be able to understand what commonly occurs when the forces or the biomechanics of force are applied to the neck. Although the cervical vertebrae are the smallest of the spinal vertebra, their bone tissues are denser than those of any other part of the spinal column. In the emergency room or trauma cervical spine, an adequate cervical spine series includes 3 views: a true lateral, which must include all 7 cervical vertebrae, as well as the C7-T1 junction, an anterior-posterior view, and an open mouth odontoid view to be able to see C1 and C2. What do we need to demonstrate on the AP or anterior-posterior view? Well, first of all, we need to be able to have a correct exposure to demonstrate all the areas of interest. And we're looking at the symmetry and the size of the vertebra. We are also looking at the alignment of the spinous processes, and we're looking for smooth and rolling lateral edges. We're looking for the disc space in between each one of the vertebrae. Here we can see we're measuring the 2 vertebrae or comparing the one above and below, and they should be of similar size. Here we're looking at the spinous processes. The spinous processes should be in alignment. If they are not aligned, we can demonstrate a unilateral or a bilateral dislocation through the misalignment. So it is imperative that the patient is positioned correctly and that you get a good quality image. Here we see the criteria for an AP Axial C-Spine. We would like to see between C3 to T1 visible without any rotation and be able to look at the intervertebral discs. The base of the skull will superimpose over C1 and C2. We're looking for optimal exposure fractures, and we're looking for the criteria of matching the vertebra from the one above to the one below. We're also looking at the spinous processes, and if you take a look at these images here or drawings, you can see that if you have a unilateral facet dislocation, you will end up with more than one vertical line going through the spinous processes. On the other hand, if you're taking a look at the area and all of a sudden you don't see any spinous processes, that's because you have an anterior dislocation of the cervical spine. The spinous processes go up and down, leaving a blank space. Also, when you look at this, you need to look at the soft tissues and the air in the trachea. Here we can see the initial lateral C-spine X-ray. Notice the patient still has the C-collar on. And with the C-collar on, you are going to have different areas or parts of that C-collar projecting over the area of interest. You should take a second lateral C-spine once the spine has been cleared. This may be after all the other images are done, but among the process you need to get a second C-spine. You want to look and see, is the image satisfactory? Do we have the shoulders down and out of the way so we can see C7 and T1? Hopefully nothing is obscured by jewelry or other opaque objects. Is the penetration okay? We don't want to over-penetrate and lose the tissue and soft tissue that we're looking at and only see the vertebra. And you need an adequate demonstration of the entire cervical spine, C1 and 2, all the way down to C7, T1 joint space. Injuries are most common in the lower cervical spine, from C5 through C7, and at the upper articulation of C1 and C2. At least 70% of detectable abnormalities will be visible on the lateral radiograph. To be able to visualize these, we need to see the entire cervical spine. The C1, C2 articulation must not be sacrificed to obtain a radiograph that adequately demonstrates C7 through T1. We're talking about exposure here. At times, we may need to get an additional view, such as a swimmer's view, to be able to see C7 and T1. Here we're taking a look at two C-spines. The fracture on the left image is obvious, and we're not going to take a secondary upright view to be able to ascertain the soft tissue, the air, and the vertebra, and the articulations of the joint spaces that we would otherwise. We want to get a nice upright C7 through T1 soft tissue with the patient in a natural position. Remember, when they have the C-collar on, they're going to have the straightened look on the vertebra. when they have the C-collar off and they're upright, the neck will go into its natural state. When the neck is done upright like this, we're going to evaluate the retropharyngeal space and the retrotracheal space. What we're talking about here is taking a look at the tissue in between the vertebra and the air coming down the pharynx and the trachea. On the upper portion of the C-spine, there should be about 1/3 the amount of tissue as related to the spine that it articulates with. As we go down to the lower portion of the C-spine, 4 through 7, there should be a 1-to-1 ratio of soft tissue to vertebra size. This image demonstrates the measurements that we're going to look at on the lateral C-spine with tissues, both bony and soft tissue, and air. You'll see there is a D, a P, and a T. The D stands for the predental space. This is where the peg of C2 goes through the circular vertebra of C1. The P is for the pharynx, and the T is for the trachea. If soft tissue spaces we want to look at, in the retropharyngeal space, we're looking at about a 7 millimeter distance at C2 on an adult. If that distance, or the tissue in between, is greater than 7 cms, and say it is greater than over 50% of the vertebra at C4 and above, then we've got a fracture. When we go down to C4 through T1, we're looking at a distance of about 1-to-1, the soft tissue as compared to the vertebra. So they would be 100% equal. If, in fact, the trachea is displaced farther out than that, again, there's a good possibility that we have a fracture. We're also going to take a look at the curvature of the lines we talked about earlier to be able to evaluate the bony structure, disc spaces, facets, and spinous processes. On the retrotracheal space, that should be about 22 millimeters at C6 and 14 millimeters at C6 in children. Remember, we're taking a look at the natural curves, and we're looking for any abnormality of the natural curves. A malalignment of the posterior vertebral bodies that is greater or more significant than the anterior would indicate that there is an injury at that level. What is going on there? We also have the clue from the AP when we look at the alignment of the spinous processes. If we have a vertebra that is less than 50% difference in width from the vertebra below, we have a unilateral dislocation. If it is greater than 50%, then we have a bilateral dislocation. We're looking for widening of the inner spinous processes to see if we have any ripped ligaments back there due to the head going farther in flexion and extension. As we discussed, we're looking at the lines, and we're looking at a dislocation here. And what we see is on the left, the vertebra is less than 50% slid forward over the vertebra below. That would be a unilateral dislocation. Whereas if the vertebra was greater than 50%, we would end up with a bilateral facet dislocation, an anterior dislocation of the vertebra. Here we see how important the open mouth odontoid view is. Both of these odontoid views demonstrate fractures of C1 and C2. To the left, we see a CT slice that demonstrates the ring of C1 being burst by the dens and the body coming up through that ring of C2. This is called a Jefferson's burst fracture. Below the CT scan, we can see the same thing using an open mouth odontoid view. We'll also note that the dens is broken off on C2. So let's take a look at the right, and we're taking a look at these little black arrows and what are we looking for. We'll go to the far right to begin with, and remember we talked about the pre-dental space. That should be like 5 millimeters between the peg of C2 and the ring of C1 as it goes around. If greater than that, we have a fracture dislocation. Going over to the left, we can see a normal open mouth odontoid view, and we can see that there is a relationship to the joint spaces and the lateral masses. We can see the ring of C1 and the body of C2 and the dens of C2 and the bifurcated spinous process. If there was a fracture, it may look similar as the large image below shows. Now, taking a look at the lateral masses, notice that the lateral masses on the outside are wider than the body of C2. And this is because there is a fracture and they've fallen down. And notice also that the joint spaces are closed. These are the hints that you'll look for with an open mouth odontoid. And at times you cannot get an open mouth odontoid view, but there are alternative views that you can use. One would be the Fuchs view, F-U-C-H-S, which is 37-degree anterior projection of the body of C2 going through the foramina magnum. The other is a change in exposure for time, and you can do what is called a wagging jaw. We take a timed exposure while the patient goes ba 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 ba, and what happens is we blur out the jaw through motion. Here we want to take a look at the pre-dental space on a lateral view of the upper portion of the cervical spine. The red line is going through the air in the pharynx. So let's take a look at the bony portions. This is the dens or the peg of C2. Remember, they're called the atlas and the axis because one rotates on top of the other. Now we're going to take a look at C1, the ring of C1, and we can see the anterior and posterior portions of C1 or the ring itself. Notice that the dens goes up and through the ring, and the articulation between the back portion of the ring on C1 and the front portion of the dens on C2 is called the predental space or anterior dental interval. We can measure this to give us an idea of injury in this area. Remember, we talked about there's a difference between adults and children. In adults, if there is 3 millimeter interval there or less, that's normal. In children, it can be up to 5 millimeters because their spine is more flexible than in adults. If that is greater in the predental space than 3.5 millimeters, we know that we have an injury to the area. And if it's greater than 5 millimeters, not only do we have an injury, we also have instability of the spine and a rupture. These images demonstrate a displaced dens, or a displaced peg of C2 through the ring of C1. To the right, we see the normal articulation, which is no more than 3 millimeters in adults. To the left, we can see all of a sudden that articulation or distance is much greater than 3 millimeters, so we have a displaced dens. On our cervical spine lateral, we also need to look at the Atlanto-Occipital Distance. This is the distance between the skull and the cervical spine. Here we have the cervical spine. Here we have the occipital of the skull. And here we have that distance. The distance from the atlas C1 to the occiput should always be less than 5 millimeters. If it is greater, we actually have an internal dislocation of the cervical spine from the skull. Increased distance may indicate Atlanto-Occipital dislocation. To the right, we have an AP pelvis view that is done on a trauma patient. To the left, we can take a look at the anatomy of the pelvis and see the relationships between arteries and veins in the pelvic area. With a fractured pelvis, there is possibility that the bones will shift and actually cut or transect the vascularity, causing the patient to bleed out. Here we see how the pelvis is stabilized. To the left, they have a pelvic band on that they put on the patient on site from EMS to keep the bony structure from moving. On the right, we have the patient in the hospital, and they have put a stabilization device around the pelvis to keep it from moving, because pelvis injuries result in death for about 25% of the patients that are part of a motor vehicle accident and pedestrian accident. Does that mean the patient always dies when it's an auto pedestrian accident and they have a fractured pelvis? No, it doesn't. In fact, here's a pretty dramatic view that the patient survived, and you can see the entire right limb was torn off after the patient was hit by the car, and the pelvic bone was totally disarticulated at the pubic symphysis and the SI joint. There's a reason that the pelvis is included in the big three. A pelvic trauma is truly life-threatening and requires an immediate response. If you have the choice between doing a lateral C-spine on a stabilized C-spine with the collar on and a pelvis, do the pelvis first. A fractured pelvis that has arterial or venous damage cannot wait to go to CT, but must be sent immediately to surgery. Pelvic fractures as a result of multiple traumas result in about 27% of the patients dying, and about 50% of these are motor vehicle pedestrian accidents. In addition to the pelvic bones, we also get to look at the articulation of the femur with the pelvis and look for hip fractures or SI joint displacement and lower areas of the sacrum and upper areas of the sacrum demonstrate well. Also, notice we can see the lower portion of the lumbar spine. So we get more than a view of the pelvis when we do an AP pelvis for polytrauma or multi-trauma. There's so much more to tell you about in trauma imaging, but as I said, what we're going to show you is the basics. Thank you for your attention and time, and look forward to seeing you in another video.